Beste collega's, vandaag opnieuw een uitzending van MST op vrijdag. Zoals iedere vrijdag overigens. Maar dit is wel een hele bijzondere uitzending. We hebben voor het eerst een gast vanuit het buitenland. Isaac Litman, de CEO en founder of Neteera Technologies, zal spreken over de technologie die zij ontwikkeld hebben. Een technologie die gebruikt kan worden om patiënten op afstand te monitoren. Een techniek die je dus thuis, maar ook vooral in het ziekenhuis kunt gaan gebruiken. En we denken als commissie dat we dat soort technologie ook steeds meer gaan inzetten in ons ziekenhuis. Vandaar dit onderwerp. Het woord is aan Isaac Litman. Hij zal een lezing geven en ik zal hem wat vragen stellen. En dat wordt ongetwijfeld zeer interessant. Dit is MST op vrijdag. Vandaag dus in het MST op vrijdag de founder en de CEO of Neteera Technology. Hij spreekt Engels en hij zit in Florida, dus we zijn heel blij dat we dat zo kunnen doen. En we gaan dus nu over naar het Engels. So, I'll switch to English. Isaac Litman, very welcome in our show, in this MST op vrijdag program. It's the first time that we have a speaker from abroad. Just from Florida, as you told us, and we're proud of it. It's very early for you in the morning, so it's afternoon for us. But thanks for coming and joining this program. And we're very happy that you're able to tell something about your company, about Neteera Technologies, and what the portfolio is. So you're the CEO and the founder. What is Neteera Technologies, and what is your product portfolio? Please, could you explain it to us?
Absolutely. Thank you very much, Kees, and it's a pleasure of joining you guys, and I hope that you're all enjoying a beautiful day in the Netherlands. So with your permission, I will share my screen so I can show you my short presentation, and I can take you through the story of Neteera. Neteera's focus is on creating some sort of a new leap, a new approach towards human biodata collection, and we think that advanced health monitoring is the basic in order to improve patient outcomes. I know it sounds vague. Let's jump into the questions and try to explain and demonstrate why medicine or the medical world need a new approach towards how to monitor patients. So when we are looking today at what happens with the remote patient monitoring and passive monitoring, we see that there is a huge need in the market. Why? Because first of all, you have what we call the hospital exodus. You have huge staff shortage, especially on nursing staff and also physicians. If you have people that do not have to be hospitalized in the hospital but can be at home, it's reduced cost. Of course, less hospital-associated infections, less AJIs. It's more comfortable for a person to be in his home, and of course, he's getting better care. And saying that, think about someone, if you don't need a doctor near you 24/7, you're better off being at home because you're in your environment, you're protected, you can get your treatment. But then the question is, how can the medical staff monitor you? There are existing solutions that fall short. I mean, here we see a solution by Livongo. Usually these solutions comprise of a hub, some sort of a center box connected with all sorts of sub-devices, whether it's pulse oximeter or blood pressure cuff or etc., etc. The problem is that these systems are providing only a spot check, a check only in a predefined time frame. Okay, it's non-specific to a certain disease. It's just a general check. Okay, and it requires patient involvement. The patient himself has to administer the treatment to himself or the vital signs and the biodata collection to himself. He needs to connect the device, he needs to put it on himself, he needs to measure it, sometimes he needs to report it. And there's a question, what happens if you talk about elderly? Because with elderly people, we have technology acceptance challenges. What happens with geriatric patients? Do we expect them to be at home and connect themselves to medical equipment? What happens with patients that have cognitive impairment? What happens with patients with motoric or visual impairment? Or people that live alone and doesn't have someone at home that can take care of them or connect them to the medical device? So the existing solutions, okay, in the market today requires patient involvement, requires the patient to do something actively or requires someone else to do it for the patient, they are very limited. And the market needs something else. The market needs something that can monitor the data in a continuous manner, not just a spot check 1 minute here and 1 minute there, but continuous data from the patient, okay? Just like the ICU, but not without the difficulties of the intensive care units. So you don't want to connect the patient to too many devices at the same time. So you want to have continuous, you want to have zero patient involvement. What is zero patient involvement? You want to be in a position that the patient doesn't have to do anything. He doesn't have to connect himself. He doesn't have to charge the system. He doesn't have to have to sync the system. He simply doesn't care. And of course, there are other reasons that you want to have solutions that are different. You don't want someone else to administer the medical device, okay? You don't want to remove clothing. You don't want the patient to have to remove clothing. You don't want to have any privacy or maintenance issues. For instance, if you're using a camera, you may have a privacy issue. And you want to have optimal data collection and, of course, remotely controlled. You want to have, in the end of the day, if we want to change the way that healthcare is dealing with the patient biodata, we want it to be completely passive. The patient doesn't care, and everything can be done remotely. So these are.
Can I have some question, Isaac? You're saying the patient mustn't be remotely controlled. The patient must have no need to remove clothing, etc. If you say such things, I only think about an Apple Watch, which I like to have, of course, but about the Apple Watch. So could you explain to us, maybe in the next slide, what the difference is and why an Apple Watch or something, just a wearable, is not suitable enough, in your opinion, to do what is needed and what you explained to us?
So Apple Watch is definitely a beautiful product. Okay, let's indeed move to the next slide and talk about what are the existing solutions. We call it the non-evolution of vitals monitoring. This is the first EKG. Okay, this is what we have today. We're still talking about wires, and when we are looking at the Apple Watch, we see it as the same category. Why? It's more comfortable than this one, definitely, and it's more comfortable than this one. Okay. But still, you have to wear it, you have to charge it, you have to sync it, you have to take care of it. Okay? What happens? Think about people that have issues, technology acceptance, geriatric patients, patients with visual impairment. I mean, they have to take the watch every time off their hand, charge it, making sure that they get it back. Listen, my mother can't even charge her phone. She finds it very difficult to connect it to electricity. I'm not talking about an Apple Watch. So I think that when we talk about Apple Watch, it still requires patient involvement and patient intervention, and he needs to do something. And again, he needs to wear it on himself, and the Apple Watch has its downsides as well. So in the end of the day, if we really want to come with a solution that requires zero patient involvement, okay, that's what the Apple Watch still is in that category. So wearables is a challenge, and we think that in the end of the day, our vision is, can we bring a solution to the market that the patient doesn't have to do anything, not even to wear an Apple Watch? And besides, you know, I was recently asked, what can be better than an Apple Watch? And I said, you know, I have an Apple Watch and I like to get the data. But what can be better than an Apple Watch? My answer is not to wear an Apple Watch, because sometimes I don't want to wear a watch. Sometimes I want to wear another watch. So in short, I want to have the data, but I don't want to be forced to wear the Apple Watch, because again, sometimes it's okay, sometimes it's uncomfortable, and I'm relatively young, yes. Think about people that are sick, people that have issues, people that are elderly. This is not an optimal solution for them.
So what you're saying, the optimal solution is something which is located somewhere in the room, I should say, what you don't have to wear, but is there and records all your data.
Exactly.
And that's the main advantage of your technology, as you're going to express to us.
Exactly. So we think that the optimal solution is the solution that doesn't require anything from the patient. And that's what we did. So we came with our solution, and we call it the 3Ds. The first D is the stressless detection. Think about the technology that can monitor the patient up to 1.5 meters from the back or from the front, sitting or lying down. So the patient has complete freedom, okay, to read a book, to lie in bed, to rest, to sit and watch TV. He doesn't have to be connected to anything, and he doesn't have to care about anything. He doesn't have to think about whether or not he's connected and whether or not the system is functioning or not. He shouldn't care about that. So the first thing, the first D is the stressless detection. We want to be able to collect biodata without the friction with the patient. The second D is the accessible data, where all the data from the system goes out to the cloud, and in the cloud it's available for the caregivers, okay, to look at, and then if the caregivers can look at it, they can get to the third D, which is informed decisions. Think about it. You are going to have a patient that you're going to send home, okay? You gave him a treatment, you chose, you know, a care path, okay? You decided to give him certain medication, certain treatment, and now he's at home. Usually you will see him a month, 2 months, 3 months later. You hope that he was able to follow the path of the treatment, etc. Here, you see a week later, if you start to see changes, if you start to see that the patient feels better, that the patient's vitals and biodata is getting better and is improving. And if you see that there is no change, the caregiver can approach the patient and simply check what goes on. Maybe the patient forgot something, maybe he doesn't take the treatment, maybe he takes it, but it's not effective, maybe he needs a different course of care. So the idea here is, in the end of the day, to connect that circle of patient, data, and the caregiver, and the clinician, the doctor, the nurse, so they can take the right decisions at the right time. And that can happen when the patient is at home, and it can also happen when the patient is in the hospital, as we know that, again, also in the hospital, when you're in the intensive care unit, you are being monitored continuously, but you have to be connected to a very large number of devices. Here you talk about the ability to monitor patients all around the hospital in a much easier manner, okay, and also reduce the workload of the nursing staff, because they don't have to go all the time and collect biodata and vital signs.
Right, they're not going to wake you up in the morning, early in the morning, because they want to know if you're still alive. Huh? That's the kind of advantage, I think.
You know that he's alive, and you know that he's well, and you don't have to bother him for that.
Okay.
So how does the technology works? As you can see, we created a very unique radar platform, okay? Think about a radar that can actually feel your vital signs. How can it feel your vital signs? Very simple. If you're looking at the next slide, you see that this is the Neteera radar. It's a very small form factor technology, 6 by 8 centimeters, very unobtrusive, okay? And the way that the technology works, it's that it sends a very weak beam towards the body. And we actually see or sense the micro skin motions that happens because of the vital signs. When you breathe, you have motion in the body. When your heart pumps, you have motion in your body as well. You have a shockwave going through the body. And we are actually a non-invasive technology. We do not penetrate the skin. We do penetrate the clothing, but we stop at the skin, and we are actually reading the micro skin motions and translate the micro skin motions into actionable data, okay? The reason that we can do what we can do with the radar is because we are the only company today in the world that has developed a very unique radar. It's a Subterranes radar. It's working at very, very high frequencies. It's the only radar in the world that works this way, and that's the heart of the system. Of course, it's coupled with very advanced AI and algorithms to understand the data that the radar senses and to translate into actionable data that the caregivers, the nurses, the doctors can understand and act upon. The radar gives us, yes, please go ahead.
If I understand it correctly, Isaac, what you're saying is that you developed a radar system which has the ability through the clothing to detect the very small skin changes, which by some kind of artificial intelligence data will give us information about the body itself. Huh?
Absolutely.
The vital body signs.
Exactly. We are measuring the mechanical activity in the body by using radars. Think about it as the evolution of technology. I mean, think about radar. It started, in the Second World War as huge radars on islands. Yes, it's moved to ships and to airplanes, and now the size of the radar is 6 by 10 millimeters. It's like your fingernail, and that thing can detect vital signs in humans. Let's talk a little bit about how it looks in the room and what are the features that we can see with that radar. So this is how it looks in the room. Right now it's located on the wall beside of the bed, so it can be placed either in a fixed installation, when you glue it to the wall, either above the bed at the headrest or at the ceiling or at the bedside wall or under the bed. It can be placed on the bedside dresser. It can be placed in front of the chair, behind the chair. You have full flexibility where to place the system in order to monitor the patient, okay? So what it is that we can see with the system today, okay? So we'll talk about the current things that we can monitor, and we'll talk about future things that are in the pipeline. So currently, we can see a lot of information regarding the heart rate and derivative and respiration rate and derivative. Heart rate interval, heart rate variability, respiration rate and respiration depth, how deep the patient is breathing, and how fast. So you can know, for instance, if he's breathing, if he has a rapid and shallow breathing, for instance, or other kinds of symptoms, inhale and exhale ratio. So you know the relations between the inhale and the exhale, very important with patients with COVID, for instance. And of course, that can be done in a continuous and in a spot check mode. Another feature that we are going to add until the end of this year is BioID. So the system can identify the patient by his vital signs, actually by his heart wave, okay? And I will show you that in a second, how that looks like. The advantage of it is that, think about the patient in the ward, in the department, okay? You know that the patient that is assigned to the bed is indeed the patient in the bed. And at home, you know that the patient that is monitored, or the person that is monitored, is indeed the patient. You are not monitoring now his grandson or his child or his wife because they were, in the same area by mistake. So you know exactly who you're monitoring. Future features include what we call initially around the bed. So we can do what we call bed exit and entry counts. We can count how many times the patient left bed at night, for instance, and came back within a short period of time. When the patient left bed at night for a short period of time, 2, 3, 4, 5 minutes, and came back, we suspect that might be that he left bed for urine, to give urine, okay? And too many times of that might be an indication of UTI. So you want to know that. It's not a prognosis, but it's definitely a way to suspect that something is changing in the patient. And usually UTI is the first indication, or urinary tract infection is the first indication of a patient that has a hospital-associated infection. The next thing that we are working on, actually on the second clinical trial, is sleep and sleep apnea, detecting sleep in patient, and also so you know if he's sleeping or not, and also detecting sleep apnea. You know if the patient have apnea events during sleep, that he's not breathing, whether because it's obstructive airways or central apnea where you have some neurological issues. For risks, we can give the nurse, if it's in a hospital environment, an indication that the patient is trying to exit the bed, and that can trigger, if that patient is in a risk of fall, that can help the nurse simply approach the patient and avoid a risk of the patient falling in the room. And another feature that we are working on and will be available by the end of the year is what we call pressure ulcer risks. If the patient is in bed and he didn't move for 2 hours, that's an indication you need to move him in order to avoid pressure ulcers. We know the laying position of the patient in bed. We know how he lies. We know if he lies on his back, on his side, on his belly, and because we see simply different reflection from the patient. We don't have any camera, so no privacy concern. So once we see that, we can give also the nurses an indication that the patient hasn't moved and it needs to be moved, especially in patients that are not moving too much. That can be a difference between getting a pressure ulcer or not. Last two features that we are working on are blood pressure and atrial fibrillation, everything that has to do with atrial fibrillation, arrhythmia, etc. This is something that will be available towards the end of 2022. Blood pressure looks very, very promising, and we are planning to have it commercialized by the end of 2023.
So what I understand of all the things that you're showing here, it's impressive, I must say. Yeah? I hadn't heard it before, because I know, of course, your company, but elsewise we didn't have this conversation. But I'm impressed about it, Isaac. What I find the most interesting in it, that there are some things that are specifically for the medical doctors, the information for medical doctors from the patient, but the other ones are especially for the nursing department very interesting, of course. When you give a risk, can you make a risk analysis of ulcers? It is an enormous advantage of the things we are doing today in the hospital. So this is quite interesting, of course. But as I always see it, and you tell it to me, but I want to have, of course, we are scientific people, we want to have clinical data. Can you show us? If it's not there, there should be some clinical trials, or maybe we can help. But please, could you show us some clinical data about what you found in combination with the things we are normally recorded? So some kind of XY equation. Could you please show us?
Absolutely. Absolutely. So first of all, we did run a number, quite, I would say, a significant number of clinical validations and clinical tests on the system. And of course, I'd be very happy to do similar collaboration or, investigations with your hospital, whether it's, general concept of the hospital or specific departments.
Somewhere in the Netherlands.
With pleasure. Listen, I love the country. So let's talk about, what we were able to show in the clinical validation so far. So initially, maybe, the how we validated the vital signs. So the first thing that we did, and we did it versus a Mindray EPM 10M, okay, capnograph and EKG. So the first thing that we did on 100 patients was actually checking a spot check. Let's do a spot check on the respiration and a spot check on the heart rate. And we saw that, and we measured it from the front and from the back, and all the numbers, are 90% and above, which are validated and accepted by the FDA. Okay, whether it's Neteera versus a Mindray, or even we did it even versus a manual nurse check, because sometimes the respiratory devices have deviations. Okay, so we wanted to make sure that both directions are working, and also heart rate versus a Mindray, we got very good results. When we worked with the continuous monitoring, 5 minutes, okay, when we actually measured second by second versus the Mindray as an EKG and capnograph reference system, we saw very good agreement between the system, front and back. Why do we do the front and the back? Because again, we wanted to show that the flexibility of the technology is you don't have to place it or to put it in a way that, just from this angle towards this. No, it's flexible, can work on the patient from the front, from the back. When he's lying in bed and he's switched around, we still work. So very good results regarding the accuracy of the technology. But let me also jump to other directions to show you how it can work. For instance,
when a simple question, Isaac. Is it already published somewhere in a peer-reviewed scientific journal, or will it be published?
It's not. It wasn't published yet. It's going to be published in the next 6 months. But the clinical research itself is available, and we can share it with you if there is any request with pleasure.
Now, just for the audience, that they know that it's not just a simple comparison which the company has done, but it is also scientifically okay, so to say. And it will be, that's important for us.
Scientifically, and it was also monitored by a CRO, a clinical research organization. So it was basically validated by a third party. It was done at the Shaare Zedek Medical Center in Israel and validated there by them with a clinical research organization. So it's definitely a third party validation. Just to share with you some more, indications of how our technology works, and this is the biometric identification, for instance. Okay. What you see here is these are names of different people at Neteera, at the company, and what you see is a number of waveforms of their heart wave. Okay, and what you can see is that different people, their waveform is similar from different times of the day and night. Okay, you can see that the waveform looks similar for the same person and different for other people. So you can actually identify people. Look, for instance, at Ohad's heart wave. It's obviously different than Hannah, than Eldar, and then Amichai. So that gives you the ability to actually look at the heart wave and identify the person. At this stage, we're not identifying a person out of 1,000. Okay, we are limiting it to 1 out of 4 or out of 5 because we want to identify the patient out of his household members. But we are going to improve it and to add. So think about the ability to have a patient at home when the doctor or the nurse that are dealing with the patient, they know that the data is validated to be the patient's and not anyone else's. And of course, think about what happens in the hospital. The ability of the nurse to approach a patient, to know that the patient in bed is indeed verified and identified by a technology, okay, when she has to administer care or giving medications. So that's another, I would say, layer of protection and of confidence to make sure that indeed the treatment given is given to the right person. And again, I think that it brings us back to the angle that you discussed before, physicians and nurses. It aims to provide more data to the physicians and more confidence to the physicians on one hand, but to help the nurses, okay, on the other, to make their lives easier and to make their job more focused on actually giving care and educating the patients and helping them rather than to do the tasks that can be done by technology.
Yeah.
Yes, please.
Right. So why does it work? Does this work? You say there's a different pattern. It is over the day completely the same, but different for different people. Is it because they have another skin or other constituent of their body or whatever? What is it? Why is this the way to identify people? Why does it work? So
the reason is that our heart, I mean, it was known previously that the different people have different kinds of course, functionality in their body, and the heart, your heart and mine are acting differently. Environmental influence, dietary influence, and of course genetic influence. So and how much you are, in good shape or not, and these things, in the end of the day, create different waveform between you and me. So if the technology is looking at both of us in high granularity, in high resolution, it can see that this is Kees and this is Isaac because it's not the same waveform of the heart wave. Okay.
Yeah. Right. Yeah. Interesting.
Another thing that we talked about is the sleep apnea, and what I want to show you here is an example of, this is a second clinical, actually it's the first clinical trial that we did. These are the numbers from the beginning of 2020. We actually had to stop doing the second clinical trial because of COVID, and now we are returning to it because we want to improve and we want to release it by the end of 2022 as already FDA and C medical approved. So this is an example of a patient in bed with a sleep apnea event. What you see here is the waveform that our system detects. It's actually the respiration, and the small notches is the heart rate. And what you have here is central apnea. The patient simply stopped breathing, and you see that the waveform for the respiration is gone, and you only have the heart rate. And this is an apnea event for the patient. And we were able to show that we can detect all sorts of apnea events, whether it's hypopnea, obstructive, central, and mixed. In total, the success rate from about 19, almost 2,000 events was 88%. That was at the beginning of 2020. Now we are much better. But again, the idea is that in the end of the day, you can use a non-invasive and passive technology to monitor the patient at night. It doesn't have to be connected to 26 wires in order to be monitored. And that technology can identify a potential apnea event and also classify the event. So think about it. In the end of the day, when you're talking about the Neteera technology, you talk about a very simple system, okay? And I'm holding it right now in my hand. It's a very simple and small system without even an on-off button that can do, it's like a Swiss pocket knife, okay? It can detect the vital signs, it can detect the identity, it can even detect apnea events. So that's the beginning, and we intend to add more and more features to that technology as we go. In the end of the day, what you will have in your hospital is every patient that will be assigned to a bed will be automatically monitored, okay, and the data will flow to the nurse station. And also when the patient is at home, the same will happen as, again, you might have a situation that you will have home hospitalization with a department of patients, really another 20, 30 patients at home. They're being monitored by technology. They were given a path of care, and they're being monitored to make sure that that care is actually working. Okay. The last thing that I wanted to show you, sorry, if you have a question, feel free to.
No. Just go on. I'd like to know the last one, the last slides.
Yes, absolutely. So we have one last slide, which is the blood pressure slide. Okay. And this is what we show in our blood pressure slide. What you are required to do based on the FDA is to have an error of less than 10 milligram of mercury, okay? and you need to have a result of above 85% of the measurement, okay? And we are actually using the waveform in order to analyze the systolic and diastolic blood pressure. So what you see here is that the systolic is, right now our accuracy is almost at 90%, okay? And the diastolic, the accuracy is at 94%. Very impressive results, but still we don't think that this is ready. It will require another year of testing, okay, before we feel comfortable to release it, because again, this was tested on 160 to 170 sessions. We want to test it on 2,000 to 3,000 sessions. We want to test it on sessions with corner cases to make sure that everything is covered. So that's an indication that that technology can definitely do blood pressure as well. It will take us more time, but it will come.
And the question is about blood pressure. You compared it with the normal situation. The normal situation is a resident measuring the blood pressure, or a very specialized doctor, or a very old doctor who has a lot of experience, or who's the gold standard in this case?
So the gold standard is also a Mindray blood pressure, automatic blood pressure cuff. So we are using that to measure the blood pressure. There is a protocol defined by the FDA how blood pressure needs to be monitored. The patient needs to be seated with both legs on the ground, and you usually do 3 measurements and you average them. So we are taking all the guidelines of the FDA and the medical regulators in order over how to test it. But I think that in the end of the day, the result of such a technology can be, think about a continuous blood pressure monitoring technology, okay, that works without contact and without harassing the patient. So that has huge value at the hospital, but also at home. We know that the hypertension pandemic is getting more and more, I would say, proliferated, in the world today. And I think that can be an amazing solution once we launch it.
So just to we're coming to the end of this conversation, of course. So what you're saying, you developed a system which is perfectly suitable for being in the hospital, but also at home, to monitor patients at home without doing them. They don't have to do anything. The technology is already available. The technology is now. I thought that it was cheap. You told me there's €1,000 for just one instrument. It's connected to the internet and calculated on the Amazon computers, etc. You told me last week. Correct. And then you can put it everywhere in the world. You can see the results of the data of a specific patient. This is an enormous, huge invention. And this, in my opinion, it does change the way we look at patients being in hospital, patients being at home, etc. Looking how to care about them, to monitor them in distance, on a distance way. Now that's not correct English, but in a distance.
Yes, absolutely. That's the vision. Yeah.
So what do you advise? Last question. What do you advise? I'm a man of now a white male in my mid-term years. Do you advise me to buy such a thing because I'm snuggling? My wife says.
So the answer is yes. I mean,
okay.
So definitely the answer is yes. Even for people who snuggle, I mean, the technology can work. Even when there are 2 people, in bed, it monitors only the one that it's looking at, at the specific side of the bed. So I mean, that in that regards depends on what your uses are. But if you want to measure your health, definitely yes. But I would say that initially it will go to people with more medical challenges. Let's get to know their data, let's evolve. But I think that in the end of the day, if you ask what my vision is, in the end of the day, we will be monitored, our health will be monitored. Every time that you'll get to your home, you'll be monitored. Your home will know how you feel. Your home will know if you're doing well or not. And your doctor will have access to a lot of data indicating what is okay and what is not okay. And he may even have an AI that can give him an indication that the patient of his, the home system sees something irregular, so he needs to look at it. Okay,
mostly my wife sees in my eyes what my feelings are, but that's another subject we're not discussing today. Yeah, so thank you very much, Dr. Litman. We're at the end of this program. I'll go on in Dutch now, have few words about what it means for the hospital and the way we think of it. Thank you very much for being here.
Thank you.
Hopefully we can cooperate sometime, or now we'll look at of course, on your website, and maybe there are some people in the hospital who want to have more information, and I know they can always send an email to you.
Of course.
Yeah? Thank you very much. Thank you for your help.
Take care.
Om even door te gaan in het Nederlands, beste collega's, we hebben dit gedaan. Het is natuurlijk geen reclameboodschap, in het geheel niet. Het is vooral om aan te geven dat deze technieken er zijn, dat die er aankomen en dat die ons leven gaan veranderen. Inmiddels zijn we ook zover, dat vertelde van de week onze innovatieambassadeur mij, dat is Boeli Tio, dat we natuurlijk een ziekenhuis gaan worden wat zich ook gaat inzetten, of dat onderzoek gaat doen naar remote-controlled patient care, oftewel patiënten op afstand volgen en kijken hoe die data gebruikt kunnen worden. En dit is een van de voorbeelden, en dan zien we dus een bedrijf vanuit een ander land, wat daar enorm aan de weg optimmert. We zijn echt we hopen jullie op deze wijze geïnspireerd te hebben vandaag in deze MST op vrijdag. En we zijn natuurlijk altijd beschikbaar voor vragen op mstopvrijdag@mst.nl. Je kunt ons natuurlijk ook allemaal zelf even in de wandelgangen aanschieten. Bedankt voor het kijken. Volgende keer is over 2 weken. Dan is er weer een nieuw onderwerp van MST op vrijdag.